Tasouli,
and we're undergraduate students at Dr. David Sahar's lab in the Department of Surgery.
Our project aims to see whether temperature during lipoaspirate centrifugation matters. As you know, fat grafting is one of the most common plastic surgery techniques used, and for this reason, it is important to understand the parameters that will yield satisfying, reliable results, both for the surgeons as well as for the patients who are undergoing fat grafting. Some parameters to consider are the centrifuge speed, the viability of adipocytes, and the temperature during centrifugation.
Plastic surgeons are still facing unreliable fat graft results. Temperature has effects on adipocyte viability through changing stiffness and deformity capacity when the cells undergo centrifugation. Since little research has been done on this matter, there is still not a resolved temperature at which the cells should be maintained and centrifuged at.
After obtaining fat tissue from 6 healthy female patients aged 18 to 60 years old, we will separate the fat tissue equally among 3 groups, each placed in different temperatures such as 4, 25, and 37 degrees, and we will measure cellular function and adipocyte viability.
After we obtained the adipose aspirates, the sample was thoroughly mixed to become homogenized and then split into 3 equal volumes in different test tubes to represent the temperatures of 4 degrees, 25 degrees, and 37 degrees Celsius.
In order to measure whether there was any damage done to the adipocytes, it is important to measure the total volume of adipocytes within the fat tissue. For this reason, after placing the samples in different temperatures for 1 hour, we will centrifuge the samples for 10 minutes at relevant temperature. Then we will add 0.01% collagenase to digest the tissue, and then we will place the samples in a shaker for 45 minutes at 37 degrees. Then we will centrifuge again for 3 minutes, and we will observe the 3 different layers that were formed, which are the upper fat oil, the middle adipocytes, and the lower soluble liquid that contains the stromal vascular fraction.
The distance of the middle adipocyte was measured by using a vernier caliper, and the volume of the middle adipocyte was calculated according to the relation between this distance and the total volume.
As you can see from the slide, we used 2 different assays. The first assay is the glycerol 3-phosphate dehydrogenase assay, also known as G3PDH, that measures cellular function and enzymatic activity, and finally the MPS assay that tests for adipocyte viability. As you can see on the graph on the left, you can see the results from the G3PDH assay, and the graph on the right shows the results from the MPS assay. After running the ANOVA statistical analysis technique, we concluded that there were no statistically significant differences among the 3 different groups.
Adipose red was used to stain the lipid droplet, and host dye was used to stain the nuclei. After observing these 2 assays, we found that at 4 degrees Celsius, the lipid droplet state shifted from liquid to solid, causing the membrane to rupture. On the top right, the observed lipid droplet under fluorescent microscopy shows a membrane rupture after digestion and centrifugation at 4 degrees Celsius. On the bottom, the top photos show the histological examination results, and the bottom 3 photos show the fluorescent results. Pictures A and D represent group 1 at 4 degrees, B and E group 2 at 25 degrees Celsius, and C and F group 3 at 37 degrees. Looking at both the top and bottom photos, you can see that group 1 had higher membrane rupture, while both groups 2 and 3 had cell intactment.
Pictures A and B show the samples before centrifugation and digestion. As you can see, the group that was placed at 4 degrees seemed to have the least amount of fat oil and the greatest amount of middle adipocytes, as indicated by the arrows. However, after centrifugation and digestion, the specific group ended up having the greatest amount of fat oil. That happens because at lower temperatures, the liquid droplet solidifies. As you can see from the graph on the right, the group that was placed at 25 degrees ended up having the greatest amount of middle adipocytes.
The MTS assay showed that the viability of the cells was maintained across the 3 groups, even though they were placed in different temperatures, and the G3PDH assay showed that the functionality of the cells was also maintained. However, the greatest difference was found in the volume of middle adipocytes across the 3 groups. Both 25 degrees and 37 degrees were found to be ideal temperatures for adipocyte viability due to reduced membrane rupture. However, since 25 degrees does not require heating, we conclude that this is the best temperature for fat grafting.
This project is also clinically important. As you know, fat grafting is used in different procedures such as breast reconstruction, bleed augmentation, and procedures to treat radiation skin injuries. For this reason, it is important to understand the different parameters, such as the temperature, that will help minimize any patient complications, as well as they will help ensure that the viability and volume of adipocytes are not minimized.
Thank you.
Any questions? So I would have to get a question. Very nice work, by the way.
Thank you.
You do everything together too in the lab? Or,
We worked primarily
Yeah.
together. However, there was also another doctor, Dr. Fan, who will also help assist with the specific project.
So my question is, I'm not sure I got this from the picture. You had 6 donors, I think.
Yes, 16
Did
more.
you combine them or did you analyze them separately?
No, we combined them.
Okay, so you combined them all together and then did the 4 degrees and 30 degrees.
Correct.
Do you think it would be worthwhile to do this where you separate each individual donor into 3? You could do with the temperature that way, trying to use the heterogeneity.
Possibly. If I'm understanding your question correctly, we did not mix all the fat from the fat tissue from the 6 different donors. However, after we took, in each experiment, after we took the fat tissue from a specific donor, then we actually basically were able to separate the fat tissue into 3 different groups. So we, in this way, we combined the results. However, when we were doing the experiment, we were basically analyzing or using the fat tissue obtained from a specific donor to do the experiment.
So then each donor was split into 3.
Exactly. Mm-hmm.
Did you see a lot of donor variation between the different donors? So maybe one temperature fit for one donor, better for another, sort of factor that into your experimental design?
We did not factor that into. However, maybe in future experiments we can be able to compare the individual donors. Thank you.
Thank you. Good morning, everyone. As Dr. Cantor said, my name is Alicia, and I'll be presenting the work done by our surgical oncology research group addressing the treatment of soft tissue sarcoma in the elderly population. So as most of you have read, by the year 2025, about 20% of our population will be greater than age 65 years old. There's an increasing body of research for treatment of malignancies in the elderly, particularly in colorectal and lung cancer. But there's a paucity of research in this area for soft tissue sarcoma, as this is primarily a disease of younger patients, but it does have a significant elderly cohort. Therefore, our objective was to analyze the clinical, pathologic, and treatment variables for elderly soft tissue sarcoma patients, and we hypothesized that elderly patients represent a distinct cohort for which age-specific algorithms are indicated. To do this research, we queried the National Cancer Database. This database is contributed to by 1,500 Commission on Cancer accredited facilities within the United States and represents 70% of all known cancer cases, excuse me. Our search yielded almost 34,000 patients with a mean age of 59.9 years. We then divided our cohort into 2 groups. The top quartile was over 75 years of age with 8,500 patients, and the bottom 3/4 were less than 74 years of age and over 14,000 patients. And of note, we excluded all patients with metastatic disease, so by NCCN guidelines, these patients were resectable. For the results, here are the differences in the clinical pathologic characteristics between the 2 cohorts. As you can see, younger patients were more likely to be Black. Older patients, on average, had a higher Charlson-Dios score of greater than 0. Younger patients were more likely to be treated at an academic facility. Elderly patients were more likely to present with larger high-grade tumors and with certain high-grade histologic subtypes. Older patients were also significantly less likely to undergo an R0 resection and to receive chemotherapy, and their postoperative 90-day mortality was 3 times that of the younger cohort. Variables that were not significantly different between the 2 cohorts included tumor size, geographic distribution, urban versus rural location, distance traveled to treatment, income, use of radiation therapy, rate of readmission, or inpatient length of stay. We then conducted a multivariate analysis for predictors of overall survival in our elderly cohort. The positive predictors were a younger age, female sex, lower comorbidities, certain histologic subtypes, a lower grade, smaller tumor size, undergoing surgical resection, achievement of an R0 resection, and receipt of radiation therapy. We then ran an analysis analyzing the grade for grade survival in months for patients receiving surgery versus not receiving surgery in the elderly cohort. As you can see here, through all of the grades, there's a significant survival advantage for patients receiving surgery. Even in the grade 4, the high grade patients, you have a 28.78 month average survival versus just under 6 months. We then performed a Kaplan-Meier survival analysis for the elderly cohort comparing surgery versus no surgery. As a whole, surgical resection had a median 43.8 month survival versus 15.4 months, and this was statistically significant. Therefore, we determined that clinical, pathologic, and treatment differences do exist in elderly soft tissue sarcoma patients. And although they appear to have inferior surgical outcomes with the increased 90-day postoperative mortality, surgery does remain associated with a superior overall survival. And this suggests a narrower risk-benefit ratio associated with surgical management of localized soft tissue sarcoma. Thank you, and at this time, we'll take any questions. Dr. Hurst. Not specifically. It's one of the limitations of the NCDB is the lack of specific confocations and only all-cause mortality data versus disease-specific survival. So our surrogate marker for that was length of stay, which was similar. So 74 and above was our top quartile. In previous research done at single institution studies and in the SEER database, the target for the elderly age is all over the map. There's 65, there's up to 80. SEER used 65 and older, but then did a subset analysis that determined inferior surgical outcomes at greater than age 75. So we felt that using the top quartile kind of put us in the middle of the previous literature that had been done, but that's certainly something to consider as a moving mark.
What now? It's interesting, right? It doesn't do anything for the 76 year old coming to. What do you want to do with it?
I think that, and this is also based on some of the other work that we've done, soft tissue sarcoma is best treated at centers of excellence, people with high volume and high experience, and also with coordinated care teams who can offer multimodality therapy, which is really important to the patient. This research is consistent that you need to consider comorbidities and overall functional status of the patient prior to resection. But Dr. Clark gave me a great idea this morning. Maybe we'll come up with a surgical selection score for soft tissue sarcoma patients. Okay, thank you.
Good morning. I have no disclosures. The database that I use is the property of the American College of Surgeons. For introduction, by 2030, we know that over 20% of the population will be considered elderly, meaning that they'll be 65 years or older. Elderly patients with rib fractures have twice the risk of pneumonia and death compared to their non-elderly cohort comparison. The target for treatment of rib fractures is these first two boxes you can see here, pain and shallow breathing. And sometimes we put our patients in the ICU so that we can really focus on these two treatments with with the thought that ICU would allow us to achieve improved pain control and give the patients increased access to respiratory therapy. However, admission to the ICU may also have unintended consequences, from something as seemingly minor as disturbances in a patient's sleep-wake cycle to something more obvious like unnecessary procedures. Additionally, ICU-level care is a limited resource. We have to have some way to appropriately restrict its use, and we would like to know that when we do use it, our outcomes are improved. My two main questions for this research project are, one, is there uniformity across centers in admission of elderly patients with isolated rib fractures to an ICU? And two, is hospital-level tendency to admit that patient population to an ICU associated with decreased adverse outcomes? To answer these questions, I did a retrospective cohort study using the 2015 National Trauma Data Bank. This is the largest trauma registry we have available, containing voluntary submissions from over 600 hospitals nationwide. My cohort was limited to elderly patients that had isolated rib fractures, so no other significant traumatic injuries. And I also excluded patients that had another clear indication for ICU admission, such as being intubated or having a Glasgow coma score less than 9. The exposure status was defined at the hospital level, so we collapsed the patient level information down to the hospital level and created a new variable that reflected the proportion of eligible patients that were admitted to an ICU. These facilities were then ranked by the proportion of the patients admitted to the ICU and put into quartiles. The primary outcome was a composite of pneumonia, unplanned intubation, and death. Here you can see the histogram for our exposure status. Across the x-axis is the proportion of patients admitted to the ICU, and up the y-axis is the percent of facilities at that proportion. So right away you can see that there is a wide distribution. The range was from 0 to 88%, with a median of 17%. And these are the 4 quartiles in which we broke up those facilities, and those will be used for the remainder of the analysis. This table highlights the baseline patient and injury characteristics broken apart by the quartiles of ICU use, with quartile 1 being the lowest proportion and quartile 4 being the highest proportion. And while you may notice that there's a significant difference in the number of rib fractures by quartile at less than 0.01, if you look at the bottom line, AIS thorax, which is the abbreviated injury scale, this score takes into account not only the number of rib fractures, but also associated thoracic injuries, such as pulmonary contusion or hemopneumothorax. So I think it's a better overall score that reflects the thoracic injury. And that was not significantly different across quartiles of ICU use. Next, we looked at a few variables that may influence variability in ICU use, and I've highlighted a couple here. On the left-hand side, you can see that ICU use was highest among level 1 trauma centers compared to level 3 trauma centers. And on the right-hand figure, you can see that ICU use was highest among larger facilities, those with over 500 beds, compared to smaller facilities. Next, we use logistic regression to evaluate the relationship between the quartile of ICU use and our outcome. Starting with the composite outcome here, you can see that there was no significant difference in the odds of an adverse outcome based on the quartile of ICU use. When we looked at each of the components of our composite outcome individually, death, unplanned intubation, and pneumonia, we do see a few significant differences. There was a significantly higher odds of death in the 3rd and 4th quartiles of ICU use, and a significantly higher odds of unplanned intubation in the 4th quartile of ICU use. There is no significant difference in pneumonia. Lastly, we decided to look at unplanned ICU admission with the thought that these facilities that are admitting more of their patients initially to the ward may have to later on in the hospital course upgrade that patient's care. Even if they didn't develop pneumonia or require intubation, there may be some other reason that we could be missing with these outcomes. However, we saw that there was no significant difference in unplanned ICU admission either. And this fact, I think, really supports the idea that the patients that are initially going to the ward, those facilities that are unlikely to admit patients to the ICU, are having good outcomes as well. I'd like to point out also that these odds are unadjusted, so we did evaluate for confounding with the factors listed at the bottom of the slide at patient, injury, and facility level. And none of these factors met criteria for confounding using the change in estimate approach, and thus they were not included in this model. So in conclusion, there is wide variability in ICU use for elderly patients with isolated rib fractures. High ICU use was not associated with improved outcomes and may actually increase the risk of unplanned intubation and death. And low ICU use was not associated with later unplanned transfer to the ICU. Thank you, and I'll take any questions. So I decided to look at it because for multiple reasons. One, our elderly population overall is growing, and this is a problem that sort of plagues trauma. So elderly patients are more likely to suffer from blunt trauma, commonly from falls. About 80% are from like ground level falls. And after blunt thoracic trauma, rib fractures are the most common injury. And we know already that those patients that have rib fractures and are elderly do worse. So our treatment often relies on this ICU level of care, which may or may not be necessary. Yes.
One, if you look at the mortality rates overall in hospitals that have the highest number, is their overall mortality rate higher? And then two, what do you do? You have a 5-year-old who will be in your trauma bay with a moderate number of cases of fractures.
Yeah.
Where are you?
So we did not look at like each facility's, I guess, overall mortality in all of their trauma patients. When we looked at the mortality, the incidence of death, there were no significant differences. Only we saw that in the odds here. And as far as what to do moving forward, so this study isn't really meant to change practice. It's more of a hypothesis generating type study. And we lose a lot of the granular detail that can be seen at the patient level when we're just looking at the facility level. However, since it's often a hospital level policy, we decided to look at it that way. So moving forward, I'm in process of doing a retrospective study with our data here using the UC Davis Trauma Registry to try to find some of those key factors that may then help us predict which patient cohort would really benefit from ICU level care. Yes.
You got a full crowd. So, go ahead.
No, so yeah. Right. So the NTDB doesn't have data based on their medications. Potentially we could have looked at epidurals if they coded it as a procedure, but I'm not sure that would have been done consistently across all these centers. So we don't have a clear picture of that. I am trying to look at some of that with my other study, though.
So that's great work. As you know, association is not part of that. And in one of your early slides, you sort of set up a model that morbidity, shallow breathing, and lipolysis and so forth. So, do you think that care is not being addressed as well? Do you think it's a surrogate for potentially hospital level quality of care issues, or is it just a potentially selection bias issue?
I think we don't know yet exactly how ICU care fits into that pathway. So we've put our patients there because we think it's going to have these benefits. But I think that especially in the elderly population, there may be some significant harm that we cause with ICU care. Increased opiates, potentially, increased rates of delirium. That could lead to aspiration, pneumonia. And so that isn't very well defined yet. So our intentions are, I think, pure, but we maybe have overlooked some of these side effects. No.
Careful about over-interpreting.
No, I think it's one of the possible explanations for it, which we'll have to look at the more granular level and ultimately in a prospective study. Yes. Yeah. So I can't tell exactly from this data why. I think that may be linked to the trauma center level. And I think that it also may be a part of a resource issue. So some of these larger facilities probably have larger ICUs. So if more beds are available, they're probably more likely to put a patient in the ICU. I think that also some of these larger facilities and level 1 trauma centers probably have hospital-wide policies on this issue, as we do at UC Davis, where essentially every elderly patient with a rib fracture is admitted to the ICU. So I think that could strongly be influencing it. Thank you.
Great.
All right. Good morning. Today I'll be talking about the predictive utility of sarcopenia and the modified frailty index in patients undergoing resection for retroperitoneal sarcomas. While the modified frailty index has been applied as a predictive model for surgical outcomes in various malignancies, it has demonstrated limited utility to predict outcomes in patients undergoing retroperitoneal sarcoma resection. Since sarcopenia is measured by average psoas muscle density, has been shown to assess both physiologic state and has been demonstrated to predict short and long-term outcomes in various GI malignancies, we hypothesized that sarcopenia would be superior to the modified frailty index in predicting morbidity and overall survival in patients undergoing retroperitoneal sarcoma resection. We looked at patients from the years 2009 to 2017. 59 patients undergoing resection of retroperitoneal sarcoma were identified from a prospectively collected registry at UC Davis. The mean age was 61 years old, 44% were male, and the histologies included well-differentiated liposarcoma, dedifferentiated liposarcoma, and leiomyosarcomas in the majority. So the average size of the tumor was 19 centimeters, 88% underwent multivisceral resection, and 24% received preoperative radiation therapy. The average psoas density was calculated at the fourth lumbar vertebrae, as you can see in this picture. Both sides were calculated, and then you take the average. And then the modified frailty index was calculated for each patient as well. Then we performed standard univariate analysis for 30-day overall and serious morbidity, as well as analysis of overall survival. Rates of overall survival and serious morbidity were 59% and 37%, including one death. Median survival was 72 months. There was no differences in rates of overall or serious morbidity based on modified frailty index scores, and similarly, there was no association between average psoas density and overall or serious morbidity. On univariate and multivariate analysis, average psoas density and modified frailty index scores were not predictive of overall survival. We did find that greater tumor size and leiomyosarcoma histology was predictive of worse survival. This graph is showing the box plots of median average psoas density by modified frailty index scores, and as you can see, there's no significant difference in psoas density by frailty index score, although we did observe a trend between lower average psoas density scores and higher modified frailty index scores. So in conclusion, sarcopenia and modified frailty index were not associated with overall morbidity, serious morbidity, or overall survival in retroperitoneal sarcoma patients undergoing resection. And further research is needed to optimize a preoperative risk stratification tool for these high-risk patients. Thank you. Sorry, say that again, did we include? We didn't look at that specifically, we didn't stratify by that. No, we just did sort of all comers that had undergone resection. Yes.
Kind of like the concept. So, two sets of questions. One set of questions, besides mortality, what about other outcomes? Length of stay, left product utilization, recovery to normal function with that. What or is it a condemnation of both these scores? That, you know, at least in retroperitoneal sarcoma resection, neither of these scores work.
Yeah, I think that may be more where we're going. Part of what we found with the modified frailty index is these patients are overall pretty high functioning. They don't have very high scores to start with. And so that may be the same problem with sarcopenia. They're not actually. Sarcopenia is also kind of a measure of frailty. So it may be.
There's enough variability in your sarcopenia or frailty indexes that
Right.
actually make it
I think that may be the problem.
Yeah, I think that's exactly what you said. You're dealing with patient population tends to be younger, tends to have fluid comorbidity, so that frailty scores are lower. That's probably why we didn't see it predicted. And similarly to the sarcopenia, we did see more of a spread, but maybe a power issue because the numbers are probably not as large as potential. It seems like sarcopenia may be more of a functional indicator of muscle mass, physiological reserve, whereas frailty index is more just what we call cumulative deficits, which is the list of the comorbidities that do not really truly show functional status. Well, the other issue is how much of it is truly reversible. So our radiology collaborator is pursuing, sort of taking this and pursuing it, and just doing scans on patients who are getting random, walking into radiology, assessing sarcopenia. Some of the other models, which I think was mentioned, grip strength and walk tests, are much more labor intensive and hard to really implement in a practical way. With sarcopenia, muscle mass, psoas muscle mass is really predictive. Maybe that can be a point of care intervention for people who are at risk of hip fracture and this and that, just as they're walking into the radiology suite. And then we also got a grant from the Sarcoma Foundation to look at it in patients who are getting treated as another biomarker of response and survival in patients. So it may be a good biomarker that's fairly easy to obtain. Everybody getting CAT scans, right? You walk into the ER and it's the UC Davis handshake. So it may have a lot of data.
First of all, two questions. One, there are over 7 trails out there, and very few of them that can be retrospective. So how did you choose this one? And then the second question is the fact that patients have a retroperitoneal sarcoma interfere with your ability to take a psoas muscle measurement? Was that area involved?
Yeah.
In your tumor?
So we use the modified frailty index, which has 11 variables, because it's been used and shown to be useful in a lot of GI malignancies. So that's what, and Dr. Cantor had done a project previously using that. So we started there, and a lot of our patients in the registry that we used already had those scores filled in. But it did decrease our sample size quite a bit because retrospectively I couldn't find all the variables for all the patients. So it did, in some cases, eliminate subjects. And then in analyzing the CT scans, sometimes it was a little bit of a stretch because it definitely decreased the area that I could measure. But we don't really know how that actually affects density, muscle density. I could usually still find the psoas, but it wasn't always that clear.
Yeah, I think those are good questions. The MFI was developed specifically to be able to explain it retrospectively through databases and registry, and it has been found to be predictive in certain malignancies, as well as said. It's been criticized as not really functional. Frailty was really patterned off of functional outcomes, these walk tests and these grip strength, but fairly late in the template, and it's really hard to do that. It's going to wear and then you work and stuff. So the true kind of functional assessment is really hard to do outside of a very well-resourced research situation. So a lot of these have been developed to try and make it more practical and applicable and good. And that's why we start to do it with something that's sort of very familiar.
Yeah, so, I first in mind the meeting that you clinical frailty for, which is critical senior support. You're not defined almost a skull patient. But it's the same problem. It just doesn't get it. Take two, ready for the culture or my patient's so close from it. I wish it.
So constipation frequently affects children. It results in abdominal pain, decreases in appetite, incontinence, social stigma. It affects both the child and the family. Bowel management programs have been developed by surgeons for patients with anal rectal malformations or Hirschsprung's disease as a method to treat fecal incontinence occurring after surgery. Given this success with achieving both continence and improved quality of life in these patients, the bowel management programs have then been applied to widely surgical colorectal disease, and that includes idiopathic constipation with all positive outcomes. So the Pediatric Surgical Colorectal Center at Shriners Hospital was developed for a multidisciplinary treatment of both surgical and medical colorectal disease. A multidisciplinary team was assembled, and it included 5 pediatric surgeons, a gastroenterologist, a urologist, a psychologist, dietitians, nurse practitioners, registered nurses, social workers, and a child life team. New patients initially met with the clinic nurse or nurse practitioner and provided an introduction to the clinic, and that included both counseling on proper nutrition as well as healthy toileting habits. Patients were then evaluated by one of the pediatric surgeons and then referred to a dietitian or psychologist as deemed necessary. We performed a retrospective review of our patients during this initial 3 years of the clinic. We enrolled 131 patients in the clinic during this time. 12 of the patients were in that first year, 46 in year 2, and 73 in year 3, which was a 6-fold increase. The median age at initial evaluation was 8 and ranged from 5 months to 18 years. 55% of these patients were male, and the most common chief complaints were constipation, soiling, and abdominal pain. Patients with anal rectal malformations or Hirschsprung's disease were treated according to previously established pathways. However, children with long-standing complaints of constipation were managed by the following algorithm. First, a contrast enema was performed. If the enema was concerning for Hirschsprung's disease, the patient was then referred for anal rectal manometry or rectal biopsy for further diagnosis. If the enema displayed fecal impaction, the child underwent medical disimpaction, and operative disimpaction was only used in those who failed medical therapy. Once the colon was then clean, patients under the age of 3 received maintenance therapy with dietary modifications, fiber, and osmotic laxatives. Patients age 3 or older received stimulant laxatives. For the patients we enrolled in the clinic, idiopathic constipation was the most common diagnosis at 65%. This was followed by anal rectal malformations at 17%, Hirschsprung's disease at 10%, and 3% of patients had neurogenic bowel, and 1% patient had rectal prolapse. The procedures performed during this time totaled 38, and that was spread across 30 patients. 16 patients underwent a procedure for idiopathic constipation, which included rectal biopsy, operative disimpaction, partial colectomy, and creation of a cecostomy or appendicostomy. 8 patients required procedures for an anal rectal malformation, which included anal dilation, Botox injections, ostomy takedown, and posterior sagittal anal rectoplasty, or PSARP.
4 patients underwent a procedure for Hirschsprung disease that included rectal biopsy, ostomy creation or takedown, cecostomy, and a redo pull-through. We assessed quality of life in our patients with idiopathic constipation starting in the 3rd year of the study. The scales included a child self-report for children's 5 years or older, or parent proxy report forms, which evaluated parents' assessment of their child's symptoms. 100 points was the maximum score. The individual questions included assessment of the child's stomach pain, discomfort when eating, nausea, vomiting, gas, bloating, constipation, diarrhea, and worry about their symptoms. The mean overall quality of life by parent report was 63 with a standard deviation of 12, and this was significantly lower than previously published scores in healthy children that had a mean of 90. Scores of quality of life by child self-report were also significantly lower, 67 with a standard deviation of 16, compared to healthy children at 89. 15% of all patients achieved long-term social continence in our program with medical management alone, and were thus able to be discharged from the program. 3 of these patients had anal rectal malformations, and the remainder of the patients had idiopathic constipation. Idiopathic constipation is one of the most common pediatric illnesses that results in significant impacts on the healthcare system, and most importantly, it affects families. We confirmed this by demonstrating significantly lower quality of life scores for patients entering our program with constipation. And going forward, we really want to assess the improvements in quality of life and determine what interventions are most impactful as we accrue longer follow-up. Over the initial 3-year period, there was a 6-fold increase in referrals to our program and the bowel management group. This increase suggests a large community need for a regional bowel management program in children regardless of their colorectal surgical history. While a majority of referrals for idiopathic constipation that we could manage medically, surgeon input was vital for disimpaction when medical measures failed and helping to rule out other pathologies such as Hirschsprung's disease. Surgeon involvement with the multidisciplinary center also helped identify patients with refractory constipation that could benefit from surgical interventions such as sigmoidectomy, appendicostomy, or cecostomy. The multidisciplinary support from providers such as the gastroenterologists, psychologists, and dietitians led to improved communication and patient care during the diagnostic and treatment process. So in summary, bowel management programs can help children successfully achieve long-term social continence. Thank you.
You guys look at all, or have you looked at all at patient satisfaction, patient or parent satisfaction, or changes in their quality of life throughout their continuum of their care?
We haven't looked at satisfaction, but part of initially developing this program was we wanted to pay attention to the quality of life scores. So as I mentioned, this was just year 3 of the program, and now it's been almost a year since that group of the 3 finished. And so we'll be able to look at the kind of post-treatment quality of life, which is really the most important thing to take a look at. Mm-hmm. Yeah. It is pretty unique having Shriners. One, it's anybody can come. You don't have to be able to pay for services. And then it takes a lot of resources to have that multidisciplinary group where everyone's available at the Shriners Hospital, even though they're not always there because we're kind of shared between UC Davis. So I think the biggest challenges are the staffing and then access to care. But it's been a big impact for Shriners because we get referrals even from kind of self networks where parents with kids with constipation are really eager to find some place that will help take care of their kids. Correct. So most, I think about 15 patients out of the total had the rectal biopsy just to rule out a Hirschsprung disease or something that would explain what was happening, and those were negative. So that